All right, let's take a break from the ECG tracings and discuss two incredibly important peptides that are associated with the natural response to increased volume and increased pressures in the heart. So these peptides are released from the atria and the ventricles. We will begin with the discussion of atrial natriuretic peptide. So first of all, just look at the name, atrial, right? This indicates that it's released by atrial myocytes. Natriuretic tells us that there's going to be excretion of sodium in the urine, and peptide just tells us about the structure. So when there's an increase in volume and an increase in pressure within the atria, the stretch receptors of the atrial myocytes are activated and they release atrial natriuretic peptide. So what does this do? So the atrial myocyte sits in elevated blood pressure and volume, and therefore they're going to start releasing ANP. So ANP is going to stimulate vessels to relax. There's going to be vasodilatation, and there's also going to be a decrease in blood volume, and we do this by increasing filtration of sodium and putting it in the urine. At the same time, we also inhibit the renin-angiotensin-aldosterone system. The atrial myocytes are not the only ones that release a peptide in response to elevated pressures and wall stress. Now, this actually should be called ventricular natriuretic peptide because that would make a lot more sense because it's released from ventricular myocytes, but it was first discovered in the brains of pigs, so they named it B for brain type natriuretic peptide. It has the exact same actions of ANP, except that it has a much longer half-life compared to atrial natriuretic peptide. This makes it very useful for diagnosing or monitoring someone that's in heart failure. So if someone presents with symptoms suggestive of heart failure, you can take a BNP level to determine what's going on. So if you're thinking about the correct diagnosis, you can give the patient a synthetic homologue of BNP called nasiritide as part of the treatment regimen for heart failure. So again, if someone has symptoms suggestive of heart failure, check a BNP, and if it's elevated, then you are able to proceed with your cardiovascular workup. But if it's low, it's probably not heart failure. All right, flash quiz, guys. In what type of heart block do the atria and the ventricles beat independently of each other? Third degree heart block, remember? This is the highest degree of block in which the ventricles are not coordinating at all with the atria due to complete AV nodal dysfunction. The SA node is sending depolarization signals to the atria, while there's an ectopic beat that's going to be telling the ventricles when to beat. All right, now we go on to baroreceptors and chemoreceptors. This is an important topic in physiology section. The baro and chemoreceptors are extremely high yield. So here is the baroreceptor and chemoreceptor diagram from your first aid books. Let's start with the location of the receptors and what they detect. There are receptors in the aortic arch here and at the bifurcation of the common carotid. Baroreceptors detect changes in pressure, while chemoreceptors detect changes in ions, particularly oxygen, protons, or pH, and carbon dioxide. These are in important places. The aortic arch receptors make sure the entire body is receiving adequate perfusion and oxygenation, while the receptors of the carotid sinus and body monitor the content of the blood on the way to the brain. Now, you're going to be expected to remember that the aortic arch transmits signals via the 10th cranial nerve, also known as the vagus, and the carotid sinus sends afferent signals via the 9th or glossopharyngeal nerve. I remember this because the left recurrent laryngeal is a branch of the vagus and it loops under the aortic arch. I also remember that the carotid sinus is very close to where the pharynx might be, and this is why it jumps a ride with the glossopharyngeal nerve back towards the brain. All right, now let's discuss the baroreceptors. These receptors are highly branched fibers that interlock within the elastic fibers of the vessel wall. So here's our vessel. Kind of like vines growing into the bark of a tree. So let's incorporate the physiology of something that we do clinically called the carotid massage. So a carotid massage is thought to be a helpful clinical maneuver because it mimics an increase in pressure. And this is responsible eventually lead to a decrease in AV node conductivity and will help decrease the heart rate so we increase the diastolic filling period. So we simulate an increase in wall pressure by pushing on the carotid body. This will essentially be the same as the vessel feeling like it's being enlarged and cause the receptors to sense pressure or stretch. This induces the receptor's ion channels to open to allow an influx of ions, and this actually leads to a depolarization of the receptors that send afferent signals. So if we're stimulating an increase in blood pressure by pressing on the carotid sinus, do you think we're going to activate the parasympathetic or the sympathetic nervous system? We're going to activate the parasympathetic nervous system because we need to decrease our blood pressure by decreasing cardiac output or decreasing the systemic vascular resistance. So some neurons in the solitary nucleus of the medulla are going to get this afferent signal, and then they're going to respond by projecting to the vasomotor region of the medulla. Remember, we want to decrease blood pressure, so what we're going to do is we're going to inhibit neurons of the vasomotor center within the medulla. This is going to decrease the systemic vascular resistance because we're going to limit vasoconstriction. In addition, there's also going to be an increase in vagal tone by releasing acetylcholine directly on the pacemaker cells of the heart. This is going to lead to a decrease in the heart rate, right? Okay, now let's discuss the response to a low blood pressure. In this situation, there's going to be a decrease in the stimulation of the stretch baroreceptors. We need to increase vascular tone, and we also need to increase cardiac output. So instead of activating the parasympathetic, what we're going to do is activate the sympathetic nervous system. In addition, we're going to decrease parasympathetic outflow. Now that we know all of that, what can you tell me about the Cushing reaction or the Cushing reflex? Well, it is a combination of elevated blood pressure, bradycardia, in the setting of an increased intracranial pressure. This diagram is going to help us understand. The brain sits inside of the skull. So here's the skull, and here's the brain. It receives blood just like any organ due to the combination of total peripheral resistance and cardiac output that is equal to perfusion pressure, right? Or systolic blood pressure. Now, the overall cerebral perfusion pressure is a term that also accounts for the fact that the brain and its arteries can be compressed by anything else competing for space within the skull. So cerebral perfusion pressure is equal to the mean arterial pressure minus the intracranial pressure. So the CPP determines if the brain is getting perfused or not. So the initial insult in the situation we're talking about is an elevation of the intracranial pressure. It's going to exceed the pressure of the arteries in the brain, so what happens is that the central perfusion pressure is obliterated. We increase intracranial pressure, and this decreases the gradient for pressure to push blood into the brain. What happens? Well, the brain is going to become hypercapnic. There's going to be accumulation of carbon dioxide, and there's going to be hypoxia, low oxygen levels. So the chemoreceptors are going to sense this, and they're going to trigger the brainstem response. So the autonomic center in the brainstem is going to say, hey, something's going on. Let's activate the sympathetic nervous system because our brain's not getting enough blood and oxygen. What's going to happen? Well, it's going to increase the total peripheral resistance, and it's also going to stimulate the beta receptors in the heart to increase cardiac output. So we've increased vascular tone and cardiac output. This is the first phase of the Cushing reflex. Now here's the tricky part. The increased systemic blood pressure helps restore some blood flow to the brain, but it will also activate baroreceptors in the carotid sinus and the aortic arch. So now we're going to activate the baroreceptor reflex because the body senses, whoa, we just did something and turned up the blood pressure super high. Let's counteract that by activating the parasympathetic nervous system a little bit. And that's exactly what happens. So the increased parasympathetic stimulation on the SA and the AV node is going to lead the last part of the reflex, which is bradycardia. So we've got increased intracranial pressure in the setting of decreased heart rate. And what's the last one? Elevated blood pressure, right? So all of these are the Cushing reflex. This is important to distinguish between the Cushing triad. The triad is a little bit different. This is a term that also includes irregular breathing. Now, why is there irregular breathing? Well, this is when the pressure in the brain gets so high that eventually the bottom part is going to herniate, and there's going to be compression of the respiratory center in the medulla, which leads to irregular breathing. Now let's go a little bit more in depth on chemoreceptors. There are two locations of chemoreceptors in general. There's peripheral and central. Peripheral refers to the chemoreceptors in the carotid body and in the aortic arch. Now central refers to chemoreceptors in the CNS. Therefore, they're called central. They're specifically on the ventral surface of the medulla. Now, both central and peripheral chemoreceptors respond to changes in carbon dioxide and pH. But it is important to remember that peripheral chemoreceptors respond directly to arterial oxygen levels, while central chemoreceptors do not respond to oxygen tension levels. Why? Well, I'll show you. Carbon dioxide is 20 times better at crossing the blood-brain barrier. As you can see here, this image, this is our blood-brain barrier, and we've magnified it to see the 3 different layers. So carbon dioxide is, boom, 20 times better at going across compared to oxygen. The brain needs to be able to change respiration immediately. There's no need to have oxygen tension feedback if carbon dioxide is so much better and faster at getting across. Another high-yield fact is that the carbon dioxide is indirectly measured by chemoreceptors in the form of hydrogen ions. So what happens is that the carbon dioxide will cross the blood-brain barrier, carbonic anhydrase will grab it, and it's going to combine it with water. This is going to form carbonic acid. This is going to dissociate into a proton and a bicarb. It is this proton that is going to be stimulating the chemoreceptors in the medulla to increase or decrease signals to the muscles of respiration and the diaphragm, depending if you need to blow off CO2 or decrease your respiration to increase carbon dioxide levels. Make sure you know this. It's going to be on your exam in some way.